once again, thank you for this opportunity. I just wanted to appreciate all the people that have spoken well. But just to give you an idea of the approach to stoma care in pregnancy, from pre-pregnancy all the way up until delivery and 6 weeks postpartum. First of all, it is a multidisciplinary approach, which means it will not just be an obstetrician looking after the patient. The most important people in this team would be the patient and the partner to the patient that is going to walk the journey with them. The partner doesn't necessarily have to be the father of the child, but has to be somebody who will consistently be there. Secondly, one of the important things pre-pregnancy in stoma care patients, because we are going to consider them to be moderate to high-risk patients, is definitely going to be the planning of the pregnancy. And in this instance, preferably if the patient is known to the obstetrician prior, that would be great. But even if they're not known, the planning of the pregnancy at least 2 to 3 months prior to the pregnancy is advisable. Because then we walk through the plan from the beginning to the end. We introduce the people that are going to be coming onto the table in this pregnancy, meaning the obstetrician will be there, the midwife will be there, the stoma care specialist will be there, the psychologist will be there, the nutritionist, dietitian will be there, the surgeon, general surgeon will be there. The physician support is also important. Should it be needed, will also be there. Importantly, I think, and I believe we'll be going towards that, that kind of a setup for all obstetricians, I'm hoping so, would be that the communication between all these people, all these stakeholders, including the patient and the partner, will not be one in which somebody just comes to the clinic on the day of the appointment or the antenatal clinic on the day of the appointment and comes back only when the next appointment is due. In my practice, for instance, every pregnant patient at the first visit gets onto my WhatsApp group. And my WhatsApp group entails all of these people. Sister Yolanda is one of them. So that if there is a challenge, seeing that this could be a medium to high risk patient, if there is a challenge at any stage, pre-pregnancy, pregnancy, post-pregnancy, delivery, there will be a communication that doesn't necessarily have to wait for the patient to come into the hospital. Somebody should be able to send a message to any one of these people on the panel in the group to say, Sister Yolanda, I'm a stoma care patient. She will be aware of the patient in any case because she will have joined the group and Sister Yolanda will be on the group. But I have X and Y challenge. So we're not having a situation where we're waiting until there's issues before then the issues have not been addressed in time, and then we're running around now at the last minute trying to get help. So I would advise any and everyone, patients, prospective patients, and even people that are passionate about stoma care. If you do have a patient that you know is planning a pregnancy or is pregnant, direct them to obstetricians within their vicinity who are going to have this multidisciplinary kind of an approach, and are going to be accessible, and they will be able to respond should there be any challenge at any given time. That's very important. I'm also wanting to say that stoma is not a contraindication to fertility, to subfertility, and to infertility. It's also not a contraindication to pregnancy. So the myth is out there that a woman with a stoma cannot get pregnant because of ABC, and that is not true. You can get pregnant, you will not be subfertile, you will not be infertile because you have a stoma. Okay. And also having abdominal surgery that has no complications as well should not impact the reproductive organs. And that is something that all stoma patients need to be aware of. So let's get into the early pregnancy stage. Once the stage is set, The pregnancy continues as per basic with everything that the woman needs to do during the pregnancy. All the vitamins need to be taken, the bookings need to be done, the bloods need to be done, and all of that. All the stages of early ultrasound, first trimester, second trimester, fetal anomaly scan, everything goes according to plan. The visits that we're going to set up for each and every stoma patient had to be individualized, because some are high risk, some are medium risk. So you need to make sure as a clinician and even as a patient be aware that your visit is likely not going to be the normal 4 to 5 week visit. It could be closer, 2 to 3 weeks. It could even be closer than that, depending on what it is that we are dealing with. So each and every patient, each and every lady has to be individualized in terms of her care. Nausea and vomiting is a very common challenge early in the pregnancy, first trimester going to second trimester. The challenge with that is going to be hydration, dehydration specifically. Education needs to be important in the sense that if you start with any kind of nausea and vomiting that is not normal meaning that you're vomiting at least 3 times, or at the most, sorry, let's say at the least 3 times a day, you need to get onto your WhatsApp, speak to your obstetrician, let them know. Because once dehydration sets in stoma care patients, it becomes kind of a challenge to reverse. And those patients sometimes just think, no, it's just a little vomiting, just a little this and that. And by the time they come into the hospital, they're really dehydrated. And I'm going back again to say the communication is important. Also, a pre-pregnancy into first trimester, your orientation as a patient is important. Meaning that after you've seen your obstetrician and you've seen your midwife, you need to sit down and have an orientation, in the sense that the patient needs to know this is what is expected of them from the antenatal care center, and also this is what they expect from us as caregivers. So it's got to be a two-way street. They need to know that it's not about we telling them what to do. It's also about them walking the journey with us. And your best patient will be the one that understands and is cooperative. Unfortunately or fortunately, there's what's called the pregnancy brain, so people forget all the things that have been said to them. And you might find that in this particular instance, it is more information that is more than information you would be giving to somebody who doesn't have a stoma. And so you need to be willing to repeat every time you see the patient, repeat what you said. In my practice, I send the WhatsApps every Monday to remind you, okay, this is what we said about this, is what we said about that, is what we said about this, don't forget this, don't forget that, don't forget that. So that people are aware and people get reminded. And don't get irritated if they come back to you and say, but I mean, what did you say that day? And you're like, I don't refer them back to the WhatsApp. You'd have to talk to them again, because that's just the way it is with the hormones and all of that. Constipation can be a challenge in pregnancy, as we know, particularly as a side effect to iron, iron being one of the supplementations that is provided to pregnant women. The side effect is constipation. We don't want to deal with stoma issues with constipation. I don't know if I'm allowed to say in this forum, there are formulations of iron that do not necessarily have to be tablets or capsules that you take. We know there's the iron infusions, but that's like something that we have to do if we have now challenges with picking up of iron. But there are formulations of iron. If you allow me, please type there, Sister Yolanda, so I can say, not say the names. But those are ones that are actually don't have to be absorbed in the gut. They get absorbed through the mouth, through the lining of the mouth, so that they bypass the stomach and we avoid constipation challenges as much as possible. Let's speak about ultrasounds during the pregnancy. As pregnancy progresses, ultrasounds can become a challenge, especially if the head of that fetus is right beneath the point of the stoma, where the stoma is. And so your ultrasound specialist or obstetrician needs to take that into cognizance. And we often find that I have to now then do a vaginal ultrasound for such a patient because the abdominal one for that particular view of the baby's head and of the pelvis is not very adequate. So be careful when you actually come in to do an ultrasound as a stoma patient to inform, to bring more extra bags and pouches, because the gel that we use on our ultrasounds can sometimes form adhesions on the pouch. And so at the end of every ultrasound, then the patient might have to remove what they came with and apply a new one just to avoid leaking and challenges like that. Imaging can become difficult as a baby grows, but then we're there to walk around that. We do say to all our patients, stoma patients included, that all your ultrasounds, your first trimester, second trimester, fetal anomaly scan, and others that you may need to do if need be, that are know that these are some of the challenges, and we walk them through that. Okay. As the tummy grows, the stoma size can change, and which is normal, which is expected, and they should be aware of that. So it might mean that they may need to have larger pouches that will fit onto the stoma. You might also find that sometimes some part of bowel also gets into the stoma. They need to be aware of that, and they need to be able to care to know how to take care of that. The more difficult part of the pregnancy is usually in the third trimester, where Braxton Hicks become, they almost feel like labor pain. And you'll find that lady running into the maternity unit, I'm in labor, when she really is not. So that is part of the discussion, to say, if you got that kind of pain, I normally say to them, come in any case. Don't sit at home, just come. Come, let's get assessed. Let's get the midwives in maternity to assess you. Call me out if I need to call out your obstetrician if she or he needs to come out. But don't just say, okay, it's just Braxton Hicks, although they will be uncomfortable. In most cases, people do think that they are in labor. Nutrition, foods to avoid is all the stuff that we normally say to our pregnant ladies, nothing special. We avoid mercury-leaded fish, which includes your tuna and your swordfish. Avoid your soft cheese. Avoid raw meat or undercooked meat. Avoid whatever obviously you're allergic to. Alcohol and tobacco is definitely a no-no. And raw meat and raw seafood, we also ask them to avoid that. However, nutrition is basically the same, in the sense that, you know, hydration, fruits and vegetables, because we need to get that bowel to keep on functioning. I normally also ask them to try and increase the protein also in their diet. And that's where the nutritionist or the dietitian also comes in the group to assist where the people are struggling. I would say speak to your doctor and ensure that you are the communication is key to any successful pregnancy, whether there's a stoma or not. The clinical psychologist comes in the instances like this, where there may be challenges here and there. In fact, the partner that walks through the pregnancy with the client, with the patient, also has their own questions and their concerns and all of that, because that person is almost usually on high alert most of the time. So it is a 9-month period of pregnancy, and those stresses are going to come in, especially towards the end of the pregnancy, when we can see now it's time for delivery, or the Braxton Hicks are telling us that we're almost there. These two people can really get exhausted. That is where the care from all members of the group needs to be heightened and more sensitized. Delivery is important. I normally advocate for normal vaginal delivery or vaginal assisted delivery for the simple reason that we want to avoid as much as possible formations of adhesions, which is common, especially bowel adhesions after surgery, after any surgery. And this is a woman who's already had surgery. However, for those who have to have cesarean sections, we do our best to do the cesarean section in such a way that we're not coming back with bowel adhesions, which is a possibility. I may add that bowel adhesions are not a common factor for stoma patients, but just a little bit of extra care after a Caesar has been done before the abdomen is closed in cases like this. I try and wash out with saline thoroughly, because there might just be a little bit of blood here and there that is and amniotic fluid that's still in the abdominal and pelvic cavity. Try and wash out, which is after you close the uterus, try and wash out like you would wash out any abdomen after any general surgery, and you find that you limit the formation of adhesions. Some people use sterile water, some dilute the saline half and half into sterile water, but just do a thorough wash. That will be of use going forward. Care after delivery for a woman that has had a Caesar, minimum 3 nights stay in that hospital. The woman doesn't leave until she has done 3 full nights, because you want to have the patient there and you see, how are you doing? How are you coping? You need to be able to educate further when they get home. You need to be able to educate with the breastfeeding and make sure that they're comfortable with that for those who opt for breastfeeding, and so on. So I do not advocate for a woman to leave maternity unit if under 3 days of cesarean section and a full 2 days of after vaginal delivery. Healing is normal of wounds, whether it is episiotomy wounds or wounds from cesarean section. Healing should be normal. Here is where the high intake of protein comes in, because we know with stomas we do tend to have a bit of insidious losses of protein, and micronutrients. So this is where the high protein intake comes in and assists a lot with the healing. In my practice, I see my patients a week after they've had any delivery, 7 to 10 days after delivery. And the normal ones you would see 6 weeks post-delivery to do whatever you need to do, health education, pap smears, contraception, and so on. But for these particular patients, I normally advise see them at least on a 3-weekly basis, meaning after you've seen them the first 7 to 10 days post-delivery, see them again maybe another 10 days after that, just to establish that they're doing good, and keep that communication open as well for them to be able to send you a message and say, or whoever send you or whoever was in the group amongst the caregivers, whether it's a psychologist or whether it's the stoma care sister or the midwife or myself or the obstetrician, to say that this and this is going on, is that okay? This and this is going on, is that okay? And so on. One of the things that you might find that might work a little bit more slowly is after cesarean section is going back to a normal bowel movement after Caesar. That's one of the things that you want to ensure after you have done a Caesar, that the bowel movement is normal. And normal doesn't mean just little pellets, like you've gone back to a normal bowel movement. That's very, very important. I also want to say that hopefully caregivers are going to go back into are going to attempt to hook their patients up, especially patients that are needing continuous care, because pregnancy just doesn't end because the patient has left your room. Pregnancy continues, and as long as it continues, you need to be able to be accessible and available. That we should be able to have in our groups access to we need to be accessible. A successful pregnancy entails that kind of accessibility, a kind of communication that is the back and forth communication. The other challenge as well with patients on medical aid that one needs to orientate them about during the orientation period early in the pregnancy is that your medical aid might not cover for all your visits. Here you are that are needing maybe more than the normal 3 or 5 visits that your medical aid covers with your obstetrician or your midwife. And try earlier on to, I normally write letters to the medical aides and motivate to say, this is the situation that we have with this patient. She will need not just the 5 visits that you guys are paying for because of X, Y, and Z. And I do find that they do comply. But that needs to happen earlier on in the pregnancy so that we're not running around with the patient now getting really frustrated. She has a visit that she needs to come and see you for. Here's a challenge that has come up, and now what does she do because the funds are not allowing her to see the healthcare provider as she should. And that's where the issues come in terms of complications, because now someone is sitting at home and has not communicated because they're worried. They're thinking, okay, there's all this money I now have to pay. Is the pregnancy this side? Is the stoma this side? So these are people that one needs to be careful in the sense that you orientate them well and you ensure that the medical aid has approved for further care. I don't know if I've missed anything or if there are any questions. If you could please just let me know.
Sure.
I'm sorry
Thank you
for the mishap.
No worries. Thank you so much. I think it was very, very informative. I did get a couple of questions come through to me directly. The one was, is the risk for developing a hernia in a pregnancy higher?
I have seen prolapses of bowel into the stoma. I haven't actually seen hernias per se, unless they had a hernia before that they weren't aware of. Usually it would be periumbilical, but hernias per se are very rare. Although if they do present themselves, then I would normally refer. I'd normally refer to the general surgeon to see what we can do in terms of hernias. Usually they don't do anything about them in the pregnancy if they are manageable hernias. Periumbilical hernias would disappear after the pregnancy. But even if they do occur, they are not usually huge, and they will not occur in the areas where the stoma per se is, because in that case, the bowel will just do a little bit of a prolapse, and that's basically it. And the stoma sister can teach them and show them how to manage that.
Okay. Thank you for that. I think the next one will probably be more for Sister Yolanda, and that is, the chances are my pouching system will change then during pregnancy, and it may change more than once.
Sorry, Faisal,
can you say that again?
So the question is, my pouching system will most likely change during the pregnancy, and it may change 2 or 3 times.
That is correct.
Correct.
Okay. Thank you so much. I hope that answered all those questions of the viewers.